You're listening to the Military Working Mom Podcast with Drea Jones, episode 40, an insider's look on what it is to seek help for postpartum depression in the military. And to do this, we're going to talk to Dr. Kristine Norris, who happened to be prior Air Force Psychiatrist. Now she has her own practice, but she's going to give us a look under the cover on not only her personal experience with postpartum depression and the various forms it takes, but also what precautions medical practitioners have to take with military members on diagnosing postpartum depression in order for their career to still be intact at the end of the day. So without further ado, welcome to the podcast, Kristine.
Thank you for having me. I appreciate it.
Of course. Well, this is such an important topic of postpartum depression because you really can't prepare for it. And once it hits you, it can come in so many different forms. So I'm just really excited to hear kind of your story and any advice that you can give to the military woman.
Absolutely. So thank you so much again for having me. My name's Kristine Norris. I am a psychiatrist, formerly Air Force. I separated last year from the military after having served 8 years with the Air Force. I did my training over at Wright-Patterson Air Force Base. So go Wright State University, Wright-Pat residency program. And then I did my remaining 4 years at Davis-Monthan Air Force Base here in Tucson, Arizona.
Nice. So you know the ins and outs of the military then, so we can ask some personal questions that I know I've received. But first, I want to know why you got into what you're doing. Like, what is your story?
Yeah, absolutely. So first things with regards to medicine, that was always something that I was interested in. Wasn't really sure if I really wanted to commit, the years in medical school, years in residency training, and all of that fun stuff. And so I really wanted to make sure that it was either working there in a museum. So I did take extra time to get an art history degree, just to get the traveling and the art history out of my system. And then eventually decided that med school was the right option for me. How I got into the military was actually through HPSP, which is the Health Professions Scholarship Program. And I actually come from a family of military folks. My dad served in the Air Force. Ironically, his first and only assignment was over here at Davis-Monthan 20 years before me. So that's how I ended up returning back home. But my uncle was in the Army. My aunt retired as a lieutenant colonel with the Air Force. I have 2 cousins who are currently in the Air Force, an aunt in the Navy, and then another aunt in the Army. So,
holy crap, you are all over the place.
Yeah. So, needless to say, the military was a really big part of our family. It's given us really good opportunity, and so it made a lot of sense after applying to medical school and realistically looking at the tuition that it would be helpful to serve time with the military if they'll have me, and also to help offset the cost of medical school. And so, I attended medical school, went to Kirksville College of Osteopathic Medicine, finished there, was assigned Wright-Patterson Air Force Base, where I did my 4 years of training. And that's actually where my postpartum adventure started, if you will. That's probably the best way to put it. So I had my first child between my 3rd and 4th year of residency. And while the program itself was very supportive, including my active duty program director, it goes without saying that there's always a bit of a pressure there to, not seek help if you don't absolutely have to. And as a trainee, the hardest part was, everyone has access, unfortunately, to kind of knowing a little bit about you if you're a resident. And so if you seek help, you're going to get the help from your colleagues. And so that was what was tough about that. And that was part of the reason why after, my first child, I certainly did experience the, signs and symptoms of postpartum depression, but I did not seek help at the time just because there was an extra pressure there, mostly coming from me, to be fair. Not to seek help. I was I was a chief resident that fourth year of my psychiatry residency program. And I had just had my first child, was expected to be back in 6 weeks because that was what we were allotted at the time. And as it was, being chief during that time meant that um, I had to ask for help in taking over my duties for the 6 weeks during my maternity leave. So there was really, for me, an obligation not to ask for any more help. And that was part of the reason why I did not, and just kind of grinned and bared through a pretty tough period. And then thankfully got a little bit better and enough to, keep going, and, was transferred to Davis-Monthan for my first like real major assignment. And then after having my second child, that's when I decided to seek help. I knew I was going to be separating. And so for me, the incentive was to make sure I came out healthy on the other side, rather than, again, trying to grin and bear it like the first time around. And so that's where my journey started with that. But outside of that, have two kids. They're awesome, 5.5 and 2.5. They're both at home with me now, as I'm sure a lot of kids are, with everything going on with COVID-19. And got a good support network here of family, husband supportive, and yeah, just really glad that I sought the help that I needed. As with anything, we always kind of wish we did it sooner, but sometimes it takes, one being ready and two being willing to seek the help at the right time.
So now,
Yeah.
what did your postpartum experience look like? Because for those that are pregnant right now or planning to be pregnant, they might not understand what postpartum depression is. And then those that may have it may not understand that that's what it is. So what did you go through?
Yeah, absolutely. So personally, what I went through was sort of the more subtle indicators of postpartum depression. That we all know, for the most part, or have at least heard of, the usual symptoms. So difficulty sleeping, difficulty eating, or even sleeping too much or eating too much, absolute sadness, just wondering if you're good enough as a mom, and then, outbursts of crying. There's baby blues, and that happens within the first 2 weeks postpartum. But really, when it extends beyond those 2 weeks, then it's less hormone, and most likely more reflective of, the emotions that come from postpartum depression. Mine was actually more subtle in that it had more to do with just overall enjoyment. The fancy word that we use in psych is anhedonia. And really what it means is just feeling like you can't get joy out of things. And so, even though, I would watch my kids go through their milestones, um, excuse me, milestones and things like that, it was really tough to feel like I could enjoy it. And you find yourself having to, excuse me, convince yourself to be present and kind of talk yourself into it. And it just felt like a lot of effort. And that's when I realized it was most difficult, was because it really just felt like a lot of work just to be there. And I think that was the toughest realization, that it was postpartum depression. So it wasn't that I wasn't happy, because I could eventually get there, but it did feel like a lot of effort, and it felt a lot of looking back instead of being present. So yeah.
I can see it's still raw for you.
Yeah. Yeah, because it's, and especially with the first year, I think a lot of moms know this, that you they grow so quick, and once they meet that milestone, they just kind of keep moving forward. And so, when postpartum depression happens for some moms, what they realize is that the milestone has already passed, and they kind of can't get that back. And excuse me, and that's usually what and that's usually what makes um being able to bond and being able to feel like you're a mom who's present, especially difficult because they they kind of do a lot of looking back, like, oh, that was really nice that that happened, as opposed to being there as it's happening. And so, um, after experiencing all of that, that's actually what made me um, explore more options from a psychiatric standpoint about reproductive psychiatry or perinatal mental health, because I didn't realize that that was honestly a thing. We always deal about postpartum depression, postpartum anxiety, just as a, diagnostic factor, and, keeping it in mind when it comes to treating our patients. But I didn't realize that it was its own kind of subspecialty within psychiatry. So, um, I think having experienced it really helped in recognizing it in patients, because again, I would see moms who could tell they really love their kids, and it was the same for me. I adore my children. They're awesome. They're fantastic, and they're really fun to be around. But I could tell that my level of joy in spending time with them didn't quite match up to how I felt about them as my children. And so that's when I knew that there was something off. And then for me, it was, the more typical signs were just even when the kids would sleep through the night, I just couldn't sleep. Or I would still kind of feel like I would have these phantom wakings at 2 or 4 in the morning and then couldn't go back to sleep, just realistically. And so I was just naturally exhausted. And when you're exhausted, everything just is extra sensitive and um, extra irritating. And again, it takes away from feeling present. And so um, with that, it made me recognize that, and especially because for my second child, I knew that we were good with 2 children. Um, I think I felt especially obliged to make sure that that I was present, because I knew like all those milestones might be kind of my last with children, or at least with our children. So I wanted to make sure that I didn't continue missing out on things that I didn't need to miss out on, basically.
Yeah, so you didn't get help
Uh,
until your second kid. So did you have postpartum depression that whole time? Because, we've heard it can last up till years after.
Yeah, exactly. Thankfully, no. It eventually, kind of worked its way out, if you will. And part of it was that after a while, it was good to just kind of talk to folks. The nice thing about being a psychiatrist working with other psychiatrists is you tend to get some variation of therapy, even if it's sort of just in a supportive, non-patient setting. And I came from a residency program that was actually very family friendly. And so that was what was nice about that. And so even though it probably took me a lot longer to recover, had I sought help after my first child, I would say that I probably felt my best about like a year and a half, after my child was born. And that was because we had gotten into a routine of, um, going to work, spending time together. At the time, I was kind of single parenting it because my husband was doing some additional fellowship training at like the other side of the country. And so it was just, my daughter and me at Davis Monthan. And thankfully we had parents on both sides. All the things we do for our kids kind of naturally extend over to us. And that includes healthy eating and taking care of yourself. And so thankfully those habits, that routine, help lift me out of that. But it did take a while. And with my son, and there was definitely a period there where I did not experience any sort of depression or anxiety. And then when I became pregnant with my son, it was for the most part a very good pregnancy, but just work stressors in general. I had just been promoted, and so with the promotion comes an extra set of administrative tasks. And I believe at the time we were about to be turning over when I came back postpartum in leadership. And so I think just sort of the natural stressors that came with work and then postpartum happening at the same time and transitioning to, two kids instead of one, all of that sort of kind of piled on top of each other. And then that's when the other round of postpartum depression anxiety happened. When with your first child, kind of the benefit is that you don't theoretically take care of any other child while you're pregnant. And so, certainly my second pregnancy was just a little tougher because we had a toddler on board as well. And I think many moms can relate to the difficulty of raising a toddler along with being pregnant and then having a newborn while also having a toddler. And while our daughter was great with him, it was just, at the end of the day, she was 3 years old and needed her own set of, attention and energy. And it was just a little bit harder when you're only sleeping every 1.5 to 2 hours, feeding your child and everything. So it was quite an adjustment. And then, yeah, the same things applied. Again, for me, it wasn't, crying or even really sadness. It was just more, I would recognize, my son would turn over for the first time, and I could tell it was supposed to be exciting, but just I just had trouble tapping into the feeling of it, the emotion of it, and that's when I knew that there was something just a little bit off. And yeah, and I had already started doing reproductive psych at that time. And so really what did it for me was I was treating patients going through the same thing, and in all honesty felt like a complete hypocrite. Telling all these moms like it's really not a big deal to seek help. I was telling these to my active duty patients and dependents of uh, active duty folks, and just felt like I needed to really, you know, actually do what I was saying and to walk the walk. And so, after about a year of treating pregnant patients and postpartum patients, just sort of felt like, what, I really need to follow what I'm saying if I'm going to be asking patients to take this risk of taking a medication or doing therapy and things like that, to help them recover if I'm not doing it myself. So
I want to stop
that's
you
what,
right there because you just said take a risk. And
yeah,
I think me and you talked about this before. So military specific now, right? No
yeah,
other
yep,
like can talk about this in the world. You have the experience. Why
yeah,
is it a risk to seek help? And why is it a risk
yeah,
to take medication when you're in the military?
absolutely. Well, and there's always sort of this global, you know, message out there that there should not be a stigma, right, for seeking mental health. But the reality is there is some stigma to it, and with regards to medication, there's no getting around the fact that if we were to start anybody on medication, if you're active duty, you're going to get grounded. You're not deployable for at least 90 days until they can find the right medication for you. It has to be the right medication. It can't be any of the medications that will effectively get you kicked out of the military. So we were always very mindful of that. Um, and also, there's unfortunately, even though we definitely want there to be no stigma, goes without saying that if you're seeking treatment and taking time out of your day to seek mental health help, just like with anything medical, there's a little bit of oh, you're taking time off again to go to this appointment or to go to this session and things like that. And that was unfortunately the reality for a lot of our patients. And like I said, we certainly try to minimize the stigma of that by explaining to leadership that, at the end of the day, we can get them back on track. They can complete their careers. And for the most part, I would say most folks did. But it's overcoming that hump of having to explain to leadership what's going on, having to reassure the patient that their career course isn't going to get moved sideways because of seeking treatment. But it's not a guarantee, and that is the unfortunate truth of it. And again, for me, I was in medical, so it was a lot more accepting. But I always did keep that in mind, that not everyone in the Air Force was medical, and that there were some squadrons more than others that generally did not encourage, seeking help, just again, because the reality is it's taking time away from manning, it takes time away from being able to deploy, and it adds to that pressure that you're hurting the mission if you're seeking help. And helping our patients kind of recognize that, and also recognize that it's important to take care of themselves first, is can sometimes be an uphill battle. So
Yeah, and that's a
that's
tough pill to swallow for some people listening, because they're, from the top, you're getting this message of seek help, nothing will happen. But you just said
yeah,
you've seen careers take a turn because they
yeah,
went and sought help.
yeah,
So,
yeah.
like, what is it, the commander that's the determining factor, or what have you seen in your experience that maybe you can
Yeah.
help solve?
It's generally been, commander to commander. I would say vast majority of the commanders that I worked with were very supportive. And so I can't say it enough that it worked out, right, for the majority of our active duty members to have sought help, and, just as many recovered. But yeah, unfortunately, there are still, you don't get up to, up in rank in the military without having been there for a very long time. And so, we did have to make efforts to try to kind of shift that mindset for some of our commanders who've just been there for a really long time, and for good reason. They're really good at their jobs. But there is also that mindset of, no, they can, just tough it out. And, why do they need help with this? Like, pilot gets grounded, that's not useful for the mission. And if someone can't deploy and someone else has to take over their deployment, that's not helpful for that family, and it isn't without ramifications. And so, definitely it takes a lot of educating and answering their questions to help them recognize that at the end of the day, they'll get their personnel back. Again, not always a guarantee. Sometimes you find that they are just too ill to continue in the military, but I would say vast majority did okay. And if the commander was supportive, it was very much an easier transition, I think, for everyone to seek help and then get back on track, than it was for the ones who really tried to fight it. So that was what I observed.
Yeah, no, it's good insight, because this is what we want, is we don't have that insight,
Yeah,
and those that aren't directly working with commanders in the decision process have no idea what's going on, right?
yeah,
So for
absolutely.
medication, I would love to speak to you on that. So
Yeah,
for our mamas that are still breastfeeding, or like you were saying, deployment, all these factors, what kind of medications can they take,
yeah,
that won't hurt, breast milk production, and won't get you med boarded, all that kind of stuff.
yeah, absolutely. Well, and so, I'm speaking, of course, to information that was up to date as of last year. So I'll preface that for now. But for the most part, most of the antidepressants that are on the market, if they are generic and they're in the formulary for, your base pharmacy, they're fine to take. Usually um, what gets active duty members, to be med boarded is usually actually more than just your usual postpartum depression, anxiety. So, the big two is bipolar disorder and schizophrenia. Basically, if you meet the criteria for those two, that's an automatic med board. And we always want to look out for those anyway, just for the safety of the patient, actually, more than anything, and making sure they're getting the proper treatment. But for postpartum depression, anxiety, I've treated several active duty mothers who are back on track, and they did deploy after some time, and it's just a matter of making sure we have them on the right dose of the medication. As I briefly mentioned, really the biggest delay is that 90-day stability requirement. But once a doc can sign off and say, you know what, they can deploy on 50 milligrams of Zoloft, for example, they can deploy, and I've okayed deployments for those, and they've come back doing just fine. So it's really just a matter of, if we're going to use a medication, that we find the right dose as quickly as possible so we can establish that 90-day stability. And and that at the end of the day, even with medications on board, as long as you're deployable, that's generally what keeps most folks from being med boarded. But to answer your question about, what's safe during pregnancy, what's safe during breastfeeding, for the most part, most of the antidepressants are, generally speaking, relatively safe. As far as we know, there are no limb deformities or anatomical deformities associated with most of the antidepressants. Off the top of my head, there's like 3 to 5, but none of those would pass the sniff test anyway, for the purposes of staying active duty. And so for the medications where you can remain active duty, relatively safe for pregnancy and postpartum. And it generally does not affect uh, breast milk production. As far as I know, I've yet to encounter medication that's heavily reduced it or anything like that. Usually the biggest concern is availability through the milk. And again, because it is such a small amount, we no longer, I'm probably aging myself, but we no longer even recommend pumping and dumping. That used to be popular, a few years back, to say, after you take the medication, just pump and dump the first round after you take the med. Now we don't even recommend that for 2 reasons. One is that the amount is so minute that really just sort of the waste that comes from mom and baby of pumping and dumping was not worth the exposure to baby. And again, as far as we know, developmentally, babies do fine. They're on par with their peers when it comes to milestones and general abilities, and there's no developmental concerns with continuing to take a medication. Um, while breastfeeding. And if anything, one of the things that has shifted in terms of how we look at postpartum depression and anxiety has been the risk of the medication itself versus the risk of having a mom who has postpartum depression and anxiety, because that in of itself has its own risks of exposure to baby, both during pregnancy and after. And what we see for the most part is that the risks of the medication themselves are generally outweighed by the risk of having a mom who is depressed and anxious, during this time. Beyond bonding, the things that we see are things like premature delivery, small birth weight, some developmental delays, in part because the emotional exchange, the bonding is delayed, and so that can affect both mom and baby in that regard. And so we find that comparing those risks is a more fair assessment of risks and benefit analysis of treating versus not treating postpartum depression and anxiety.
Yeah, not a good point to make that you said, it's not the medication you need to worry about, it's how you are feeling and how what you're
Exactly.
going through. So
Yeah.
really enjoying this. So as we wrap up, I want you to
Yeah.
let me know your opinion on, so for women in the military, should we seek help through military providers, or should we just suck it up and go elsewhere where it's not on our record? What would be your opinion on that?
Yeah. And everyone is different. So I will be, you know, definitely frank about the fact that, if you are in one squadron, it is just realistically more beneficial to go off base and seek that help yourself. But for the most part, I would say that most mental health clinics I can speak only to the Air Force, but I would say that this is probably the case for all the other branches as well, is that, seeking help is always going to be better than not. Career aside, after we retire, at the end of the day, we're going to be with our families. And so if we're going to, speaking of risk, weighing the risks and benefits, for me, what I finally weighed was the risk and benefit of, being with my family versus trying to preserve what I knew to be a very temporary career progression. And so that was part of what prompted me to seek help, was really because I knew at the end of the day, I was going to get out of the military, whether as a separated member versus retired. Um, but what you don't get back, or what you don't ever actually get away from, is the family that you're taking care of, the family who you're with. And so whatever can make that relationship better, and a healthy mom is going to always make that relationship better, is always the better route to go. And at least it's been my experience. So first off, shout out to the mental health clinic at Davis Monthan, is that they are a very, very supportive bunch, and they are among the more talented staff that I've ever worked with, especially for this population. They're very aware of what's available to our patients, um, even if they might not be able to do the work themselves. But all are very competent and very capable of helping our military members, especially our mothers who are military members. And so, I would always say err on the side of seeking help, because, at the end of the day, your career can change, but your family won't. So I
That's such a
say,
strong message. Yeah,
yeah.
strong and
Yeah.
powerful. So
Yeah.
thank you. Thank you
You're
so much for
welcome.
being on. If our listeners have any questions, where can they reach you?
Yes. So best way to reach me is through my website, which is, you can probably tell where I work, is Tucson Outpatient Psychiatry. And so psychiatrytucson.com. There's a messaging area there where you're welcome to reach me. You can also email me at drnorris@psychiatrytucson.com.
Perfect. Thank you
Uh,
so much, Christine. I
Thank you so
appreciate
much for having me. Have a good one.